So initial and serial evaluation of heart failure patients. Of course, every time they come, you're going to do your history and physical. You always have to find out what's going on with the patient. You have to do vital signs. You may want to do a repeat 12-lead ECG. Uh, Definitely wait. But the first time the patient, the first encounter you're gonna have with this patient, or if it's a, you know, it may be an established patient, but if they're developing heart failure for the first time, you have to get your chest X-ray. As we mentioned before, chest X-ray is a class 1. You have to get it. Echocardiogram is also a class 1. The radionuclide scan is if the echo is not adequate and you want to get another test to look at the ejection fraction, then the radionuclide scan is very good. MRI and CT scan is very, very important in cardiology, looking at cardiac patients, especially heart failure. And we're gonna, go into it a little bit more. Myocardial perfusion scan if you're looking for coronary artery disease, ischemia, very important. And these are again the class of recommendation. So class 1. So your new onset heart failure, those patients should have a chest X-ray. They should have a two-dimensional echo, repeat echo if it's warranted. You're not going to do unnecessary echo. As we had mentioned before, your chest X-ray will show the heart size, if there's pulmonary congestion, if there are other causes for the heart failure. Your two-dimensional echo is, it's like a part of the history. It has to be done because it will tell you whether you're dealing with heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, tell you about valvular, what's happening to the valves, wall thickness, among other things, and it should be done. Okay. Some of the non-invasive tests looking for myocardial ischemia, that is blockage. So we're going to do tests that look for blockage, tests that look for viability. That is if there's any living muscles in the heart. Because if you get a heart with an ejection fraction of say 25%, 20-25%, there may be minimal living cells inside there. So you do bypass or you do stents, it's not going to help the patient. So, okay. All right. So chest X-ray. So, all new patients with heart failure have to have a chest X-ray. You can look at the heart size. So you can, make a rough assessment, this heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, or some valvular pathology, okay? Or maybe something else. It may be a pneumonia, it may be COPD, okay? So when you get a regular X-ray, you have to know what are the landmarks on the X-ray. So, of course, we have our trachea coming down, and it's split. Uh, so you get the right main stem bronchus, and then the left, and then the carina is where the bronchus splits. Okay. Um, the angle between the right and the left main stem bronchus is important because when you have left atrial enlargement, it's going to push it up. So when you look at the chest X-ray, this angle, the angle between the right main stem bronchus and the left, is going to be pulled apart. So if you look at a lot of chest X-ray, you know what the angle is supposed to look like. If you have left atrial enlargement and it's pushed up, you'll have an assessment. So when you look at the chest X-ray, of course, this is the heart, and then the lungs on both sides. Okay, you're going to have some humps. Okay, the first hump you see there is what we call the aortic knob. This is when the aorta curves. Remember, you have the aortic arch, and then it curves down to the descending aorta. So this aortic knob is that. And then the next hump that you're going to see is the pulmonary artery. So if the pulmonary artery is not prominent, it's not gonna you're not gonna see a very prominent hump. And then the next hump, if there's a hump, there is the left atrium. So if you have a prominent hump right there, then you have left atrial enlargement, and then the left ventricle comes down. Majority of the anterior aspect of the heart is the right ventricle. The right atrium is right over here, so if you have right atrial enlargement, you can see that. So, and then these things coming out here, these are the pulmonary, so the pulmonary artery, you see it start humping there, but the pulmonary artery comes down. If it looks very prominent, that it may be dilated. So you have the left uh, uh, main pulmonary artery, and then the right is over there. Okay, and then these angles, what we call the costophrenic angle, supposed to be sharp like that. You see, they're supposed to be sharp. If they're blunted, then it's going to suggest that there's fluid there. So it's important to know what your normal chest X-ray look like. So when someone comes with an abnormal chest X-ray looking like this, you know definitely that it's abnormal. You can see that the right costophrenic angle is blunted, so this is fluid. The left costophrenic angle is also blunted, so that's fluid again. And then the heart is huge. The heart is very big, and there you can see these vascular congestion, not only in the right lung but also in the left lung. And then we talk about the hump. So you have a very prominent aortic knob right there. Okay. Uh, so you when you look at the chest X-ray, you should be able to make some assessment. So this is another chest X-ray showing a very globular heart. Okay. So you can see. So remember, we said over here is the right atrium. So the right atrium is also enlarged. And when the border goes straight down like that, it suggests right ventricle enlargement as well. So this is a very huge heart, and there's some pulmonary congestion there as well. Okay, so essentially that's that's your chest X-ray. So you need to order a chest X-ray, and you should be able to read it, but the radiologist will read it for you, but you need to look at it and have some sense as to what's going on. So the echo, again, that is another class 1. All patients coming with heart failure should get an echocardiogram, and as we said, it's one of the most useful diagnostic tests. You can identify abnormalities of the myocardium, that's the heart muscle. You can see problems with the valve itself and the pericardium. We can do ejection fraction. We can look at the size of the heart, ventricular dimension, the wall thickness. We can calculate ventricular volumes, chamber geometry, and wall motion. So we can also look at the right side of the heart. So we can look at the right ventricular size and function, the atrial size and dimension, and again, all the valves. We can check the filling pressures, the left atrial pressure, and we can also estimate the right ventricular systolic pressure and the pulmonary artery systolic pressure. So the echo gives you a lot of information, not only structural, but it gives you hemodynamic information as well. Okay. And when you do serial echo, you can see reverse remodeling when the patient is improving or or deteriorating, you can get an echo and you can see what's happening to the ejection fraction and the hemodynamics. As mentioned before, whenever you change any therapy and you want to assess whether the therapy is working, yes or no, you get an echo, okay? 3 to 6 months. But just routine repeating the echo is not recommended. So this is probably what a normal echo looks like. So those of you who do echoes know that this is a parasternal long axis view. This is the ventricular septum, the left ventricle. This is the posterior wall. And this is your mitral valve, the anterior leaflet, the posterior leaflet, your aortic valve right there. This is the aortic root, ascending aorta. So this is what probably a normal heart looks like, the four-chamber view. This is the left ventricle, the ventricular septum, right ventricle, right atrium, atrial septum. This is your left atrium and your mitral valve. So chambers are not very dilated. The valves look okay, as opposed to a heart looking like this. You have big chamber. Even if you don't do any measurement, you can see that the left ventricle is dilated. Okay, this is a diastolic frame where the mitral valve is open, huge left atrium. Okay, and this is the four-chamber view corresponding to that heart. The left ventricle is huge. So this patient would have a dilated cardiomyopathy. And then we do Dopplers. So we mentioned Dopplers. We look at the right ventricular function. When we do right ventricular function, we look at the lateral tricuspid annulus, and we look at the velocity. So this little velocity, so this is our systolic velocity, and then in diastole we have two components. We talk about a E prime and an A prime, but we measure the systolic velocity, and we like to see that above 10 centimeters per second. That suggests a normal right ventricular systolic function. And we also do something called TAPSE, tricuspid annular plane systolic excursion. And basically what we do, the lateral tricuspid annulus, you can see the cursors across the lateral tricuspid annulus. We look to see how far up it moves. And it should move up at least 17 millimeters. So we measure that. So right here it's about 21 millimeters. So it should be more than 17 millimeters. So those two things will give you some assessment of right ventricular systolic function. And then we look at we can assess left ventricular myocardial properties. And when we're looking for diastolic dysfunction, one of the things we look at is what we call tissue Doppler. So this is a tissue Doppler. We can do it the medial or lateral aspect of the mitral annulus. And when we do the tissue Doppler, the medial annulus, so we just put the cursor there and press our tissue Doppler button, and you get your systolic excursion and two diastolic component. This is your E prime and your A prime. We look at the E prime because the E prime give you a very accurate assessment of diastolic function. If your E prime is less than 8 centimeters per second, then you more than likely have some amount of diastolic dysfunction. So the Doppler echo is also important. And then we grade the diastolic dysfunction. In order to grade the diastolic dysfunction, you have to look at what we call the mitral inflow. We just put the cursor across the mitral valve and we look at the blood flowing from the atrium into the ventricle. So it's a mitral inflow. And you get a Doppler pattern. You have an E and an A velocity. In a normal young individual, the E is supposed to be much larger than the A. But as one gets older, the E gets smaller. When you develop diastolic dysfunction, the first thing, one of the earliest thing that happen is the E gets smaller. And then as the diastolic dysfunction gets more severe, then the E revert back to getting bigger and bigger and bigger. Okay, so we use the tissue Doppler, the mitral inflow, to look at diastology. Um, and we can come up with the grade of diastolic dysfunction by looking at those things. Okay, so remember what we said, a lot of our patients have stage A and stage B heart failure. So stage A and stage B heart failure, these patients have no symptoms. Your stage A patient, all they have is risk factors, hypertension, diabetes, dyslipidemia, syndrome X. Um, so that's all they have, you know. So you have to pick up those things and treat them. Some of them also, with your stage B, they're gonna have some underlying cardiac pathology, and unless you look for it and find it, you're not gonna know. So this would be if this patient is asymptomatic, there would be a stage B heart failure without symptom but have structural heart disease. So this patient has a artistic configuration of the anterior mitral leaflet, and the mitral valve doesn't open properly in diastole. So this patient has mitral stenosis. And if you pick up what's going on early, you can treat the patient before the patient develops heart failures. Okay, this is just the four chamber view, restricted mitral valve, so therefore the atrium is huge. Okay. Um, MRI. MRI is extremely important in cardiology, in our assessment. It helps us to just look at the anatomy. If you want a very accurate assessment of cardiac anatomy, the MRI is the way to go. Like, if you want to look at inflammation of the heart, myocarditis, MRI is the way to go. Sarcoidosis, that's how you're going to make your diagnosis. But MRI can also help you in looking at the volume and ejection fraction. Even more accurate than echo. We don't use it because it's a more cumbersome machine, and it requires a lot more to get these information, and it's more expensive. So we do echo, but it's much more accurate than echo. You can also do myocardial perfusion viability studies. You can look for fibrosis. And again, if you have sarcoidosis or myocarditis, you have to do an MRI. Okay? So again, anatomical resolution. Patient comes with chest pain, and you find that the patient having pericarditis. The back of your mind, you should be thinking about myopericarditis, especially if the cardiac enzymes are elevated. If the cardiac enzymes are elevated and you suspect that in addition to the pericarditis, the patient may have a myocarditis along with that, then you have to get an MRI. And the MRI gonna give you these enhanced, so you get these enhanced gadolinium enhancements, so it's gonna look white, okay? And so your MRI is very, very good in picking up acute myocarditis. And your sarcoidosis, remember that's a patchy disease. So you get your MRI, you get a lesion there, you get a lot of skip lesion because it's not a uniform thing. So it's very important in myocarditis as well. CT scan, similar to your MRI, very important. And then as we talk about the radionuclide ventriculography, we used to do this a lot. When echo was not as accurate in giving the ejection fraction when we didn't have endo, endocardial border detection devices. We have microbubbles. We can look at the endocardial border. We can give accurate ejection fraction. Before we had that, then we used the radionuclide ventilography a lot. We don't use it. Okay, this is a nuclear test, and you can get accurate ejection fraction with it as well. So coronary angiography. So if you suspect that the patient is having heart failure because of blockage, you have to do an angiogram. So if you have a patient, ejection fraction 30%, patient is in heart failure, and it's reasonable to just go straight, once a patient is compromised, to go straight to your coronary angiogram instead of doing a stress test if the patient have a depressed LV function. So this is what a coronary angiogram looks like. So this is our catheter. It's in the left main coronary artery. We inject dye in it. It outlines the left anterior descending coronary artery, and this is your left circumflex coronary artery. You see these are nice, good, smooth vessels. So this is the left main, left anterior descending coronary artery comes there, and the left circumflex. So as opposed to a patient who have a nice little blockage right there, okay? So this is your left main, and the LAD, this LAD as a significant stenosis right there. Just imagine this completely closing off, then all the vessels downstream will be devoid of blood, and then all of this muscle here would suffer, you know. So, this is a patient that if you find a patient like this and they have depressed LV function, heart failure, then you need to fix it. So we'd put a stent in this lesion, a stent across that lesion. Nuclear study. So patients who develop heart failure and they not having any chest pain at the present time, but they may have had exertional chest discomfort. Or you may do some other tests and it suggests that they may have some sort of blockage. So we have these, we call these or single photon computerized tomography. So these are nuclear studies, SPEC study. Okay, so it looks cumbersome, but it's relatively straightforward. So the slices are similar to what we get in the echo. So this would be your short axis, okay? And then we're going to do a resting image and a stress image, just like we do a stress echo. This is the vertical long axis. So it's like a backward parasternal long, okay? And then this is your horizontal long axis. So again, just like your echo, the anterior wall is there, inferior wall, your septum, your lateral wall, okay? This would be the anterior wall and the inferior wall. So we're going to compare the resting image to the stress image. So if it gets worse with stress, it suggests you have a blockage. So, you have a defect in rest and the same defect in the stress. So this would be an infarction because you have a problem at rest, no blood flow to this area at rest, and with stress, the same. So this would be an infarcted area, okay? Um, then when you look at down here, pretty much the same thing. So this would be like an inferior wall infarct, but you can have ischemia, and the same test we do. We look at the rest and the stress. Now, right heart catheterization in heart failure. 20 years ago, all patients who come in with heart failure will get a Swan-Ganz catheter, a right heart cath. We stopped doing that. Okay, we stopped doing that. But all patients with heart failure 20 years ago had a right heart catheter. It did help us somewhat to manage these patients. What we do, we put a catheter uh, in the right side of the heart, so you can go through the jugular, um, the subclavian vein, or whatever venous access into the right heart, and we put the catheter in the pulmonary artery, where we can measure pulmonary artery pressure, we can measure the RV pressure, right atrial pressure, we can do cardiac output and all that sort of stuff. So we it's no longer, we don't do it routinely anymore, because what we have found over the years is that it did not help us tremendously in monitoring, in treating these patients. So we stopped doing routine right heart cath. We use it if the volume status is not clear and the patient is refractory to initial therapy. If we're not making a headway, then we need to know the more accurate hemodynamics. What's going on? What is the wedge pressure? So when we say wedge pressure, we're talking about the LV filling pressures. So are we really dealing with heart failure? Because if we're dealing with heart failure, the left ventricular filling pressure should be elevated. It should be elevated. So if it's not elevated, then you're dealing with something else. It may be uh, it may be pulmonary edema from non-cardiac cause. So the important thing is that when we have heart failure, it means the heart is failing. So if the heart is failing, the left ventricular filling pressure is going to be elevated. So we measure that. And we used to use, when we do the right heart cath, we used to follow the filling pressures and stuff. But, it didn't help us tremendously unless the patient is not doing well. Okay? Um, if the patient is hypotensive and developing worsening renal failure, then yes, it may help you. But in the routine heart failure patient, no, we don't do it. However, if we're referring patients for heart transplant, then we have to get some right heart hemodynamics that you get when you do the right heart catheterization. Or if you're going to do a mechanical cardiac support device, then you need to know what the right heart cath shows. And then if the patient is in cardiogenic shock, systolic blood pressure less than 100, then you should get a right heart cath to help you to manage these patients. So the last lecture we're going to do is mechanical cardiac support. So this is all the mechanical device that we can use to help the heart function as a pump. We have a lot of them. So we let one of the cardiac surgeons talk to you about the mechanical cardiac supports. What support you can give to the heart. So we only do right heart cath if the patient is really, really sick. We're not sure what's going on. If they're on IV inotropic infusion, that is, when the patient have real bad heart failure from reduced ejection fraction, say 20%. If the patient have real bad heart failure, ejection fraction 20%. I'm just pulling a number, maybe 30%, but they're not responding to regular therapy. You may want to use a medication that increase the contractility of the heart, and that's what we call inotropic agent. It's a medicine that can help the heart to contract. You need to do a right heart cath to look at pressures and stuff like that before you do that. And again, if patients have a lot of symptoms despite your adjustment of therapy and doing all the great stuff, they're not getting better. Um, Left heart cath, which is what I showed you, the coronary angiogram, if the patient is having heart failure with angina, heart failure not without angina, but if this LV systolic function is depressed, heart failure, ejection fraction 30%. You need to know what's going on with the coronaries, so you do your angiogram. Um, so endomyocardial biopsy. So this is when when you biopsy something, you take a piece of the tissue, you put it under the microscope, you look, and you can see. Sometimes you can see what's going on. Is there inflammation? Is there a cancer there? So the biopsy can help you to make an assessment. Very rarely we do endomyocardial biopsy. So, and then the people who are doing the exam need to know, because since we don't do it as much, so we're going to do endomyocardial biopsy when you're seeking a specific diagnosis that's going to influence therapy. So you're not going to do it for any comers. We do it in patients with cardiac rejection. Patient with transplanted heart, if you suspect rejection, as a matter of fact, in the first 5 years in these patients, you're going to do multiple in the myocardial biopsy. But that's one of the best way to look for rejection. Okay. If you have a good determination that you're dealing with primary cardiac amyloidosis, then you can do your endomyocardial biopsy as well. If you're talking about giant cell myocarditis or any other active myocarditis, then you can do it. But you don't do routine endomyocardial biopsy. You never do it. So we talk about those things, hemodynamic monitoring, we spoke about that. Okay, so we're going to stop here, and then our next few sessions, the next set of lectures is going to be on treatment. We'll talk about the treatment of stage A and B heart failure. So these are heart failure without symptoms. Stage A is the patient who just have risk factors but no symptoms. And then your stage B patient have structural heart disease, no symptoms. So we're going to talk about those first, and then we'll move on to your stage C, which is the regular heart failure patient. These are patients who have heart failure, currently having symptoms or have had symptoms before. Those are your C. And then your stage D, these are the patients that you're going to treat aggressively. They can't leave the hospital for whatever reason. And these are the patients that we give mechanical cardiac support therapy. So our next series of lectures is just going to be treatment. But before we go on to treatment, you have to have a firm understanding of, what is heart failure? What is the burden of heart failure on the society? How can I modify it? And then you go on to therapeutic interventions. All right, so we're gonna stop here until next Tuesday. We'll look at stage A and B heart failure, the treatment of it.